Good evening, everyone, and welcome to the EUROGEN webinar series. Thank you very much for being here with us this evening. So just before we get started, I'd like to take a couple of minutes just to explain a little bit about what a European reference network is and does. So EUROGEN is one of 24 European reference networks created and funded by the European Commission since 2017, and they cover all medical fields. And EUROGEN is focused on rare urorectogenital diseases and complex conditions. And we're currently a network of 56 highly specialised healthcare providers in 20 member states. And our aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. And they are all patients who need highly specialised surgery. So it's where the expertise is rare. Some of the activities we do together as the network, well, I hope you took note of the slides at the beginning. We have a very secure IT tool given to all the reference networks by the European Commission called the Clinical Patient Management System. And this allows us to do safe cross-border virtual consultations on these very complex cases. So please, if you have one, we really encourage you to contact us and use the service. Our experts in the network would be delighted to have a case discussion with you. And this is completely free of charge to any healthcare professional who's working in the EU. We also collaborate on education and training activities. And very excitingly, another thing that we have is a EUROGEN patient registry. So obviously, if all of our 56 healthcare providers contribute data to the registry, then we hope that over the long term we'll have a very rich resource to do research, and it will also allow us to have the evidence for our work on clinical guidelines. And then finally, I'd just like to mention our fabulous book, Rare and Complex Urology. I would strongly encourage you to buy it. It's a collaboration between all the experts in the network. So it really is the latest scientific and medical knowledge on the subject. So this evening for you, we have a fabulous webinar, New Techniques for Vestibular and Perineal Fistula. As Parmida mentioned, it's also in our special colorectal series. So it's an absolute honour to have with us this evening two experts. And we have Professor Ivo de Blaauw, who's a paediatric surgeon at the Amalia Children's Hospital in Radboudumc University Medical Centre in Nijmegen, which is, of course, the coordinating hospital for EUROGEN. And our presenter here this evening. So we are incredibly honoured to have Dr. Andrea Badillo, who is Professor of Surgery at George Washington University School of Medicine at the Children's National Hospital in Washington, D.C., USA. This webinar is eligible for EACMA accreditation for those who attend the live session and complete the post-webinar survey within 2 weeks. And it's kindly supported by ESPU, EUPSA and the ARM-Net. So thank you very much again for sharing your expertise with us. And I'm going to give the floor now to Ivo and Andrea. Thank you.
Okay, thank you, Michelle, and welcome. I'd like to welcome everybody to this webinar too. And it's an honor and a pleasure to introduce Andrea, who will talk about the new techniques for vestibular and perineal fistulas. I will share my screen as well. As you probably everybody already knows that in the 80 and 81, Professor Peña and Albert and Peter de Vries revolutionized the care of anorectal malformation, particularly the surgical care. by introducing the PSARP. And it was Professor Pena who implemented this for the most of the time. And it was used for all kinds of anorectal malformations. From the simple perineal, I wouldn't really like to call them simple, but let's say the less complex perineal fistulas to cloacas.
Sorry, Ivo, sorry, excuse me. Are you sharing your screen right now? Because I think you need to reshare it.
Not yet. I need to share. Yes, very good. I will share it now. Can you see it now?
Yes, great, thank you.
Well, I'll start all over again. No. So there was Professor Pena who introduced it and implemented it, and it was used for all kinds of all anorectal malformations, and even for the cloacas. The sagittal incision was introduced. It was even became smaller to a total urogenital mobilization. And for the bladder necks, laparotomy was added, was of course added to it, but it was replaced by laparoscopy. But you could use the PSARP for all procedures. Now, if we look more closely to the perineal and vestibular fistulas, other techniques were still available and still used, and some of them are reintroduced now and even refined. And most of them are focused on either sparing the perineal body, the perineum, or sparing the sphincter, which in the PSARP you tend to cut everything from the beginning. So the anoplasty is one of the techniques which really wasn't completely abandoned. A lot of males with perineal fistulas were still operated by many surgeons with a very relatively simple anoplasty. The ASARP was introduced in 1992, where you not only position the patient differently, but you don't cut the posterior part of the sphincter muscle. And we'll talk about it today. Some people who were really trained into the PSARP procedure were looking for sparing techniques. That's the perineal sparing technique. But even sphincter sparing techniques have been used in the past and are still being used and reintroduced. And well, today it's a pleasure to have Andrea talk about two techniques for perineal and vestibular fistulas, which have not recently been introduced, also to be less invasive in the less complex kind of malformations we have. So Andrea, the floor is yours, and the questions everybody has, they can ask by the chat, and we'll have a discussion at the end as well. But Andrea, first, I'd like to give the floor to you after I stop sharing my screen.
Well, thank you very much. Let me go ahead and share mine. And then I think we're good here. Am I sharing? Yes. Okay.
Yes.
So again, thank you for the invitation and the opportunity to speak. It's an honor to be here with you this evening. It's lunchtime for me. I have no conflicts of interest to disclose. As an individual surgeon, we start to view our work through the lens of how do we avoid complications, how do we improve outcomes, and look at all the choices that we have to make through that lens. In a referral center, we see many complications and sometimes the less frequent ones, but that also come with sometimes high associated morbidities. And this perspective, I feel, has been a key driver in the development of these modified techniques that I'll discuss today. And the question being, what strategies, what modifications can we make or employ to reduce these complications? And so has anyone had this complication? Yes, no, prefer not to answer because it's too painful.
I prefer to answer, but it has happened.
I think you're able to answer it now. I have opened up the poll section.
Okay.
And people are answering, so I'm going to wait a couple of more seconds so more people can answer.
Okay.
It's only about the first question that I've made visible. So I see some people are answering the second question as well, but that's going to come further down the presentation.
And so I'll just sort of describe the picture. The anaplasty has separated some from the margins, and then we're also seeing breakdown of the perineal body. Separation and dehiscence have been reported at rates anywhere from 26 to 40%, even in some series for rectovestibular fistulas. Some more recent series report more of a 3 to 6% rate, and I think looking at the responses, majority of us have had that experience, unfortunately. And this separation can range from the incision requiring local wound care to complete dehiscence with retraction of the anaplasty, potentially requiring diversion with colostomy. Subsequent perineal scarring can result in anterior migration of the anaplasty and shortening and loss of the perineal body length. And these anatomic changes have implications for both future continence and obstetrical outcomes. Loss of the muscle anterior to the anaplasty can impair continence, and maintaining integrity of the perineal body structure is important for vaginal deliveries and avoiding obstetrical related sphincter injuries.
I have now closed the question, and I could see that about half of the attendees had answered, and about 63% said yes and 32% said no.
And then this window, do I just close it, or the poll window?
I think I might have closed it, or are you still,
still
able to
seeing
see
one?
it? Oh. You can maybe close it, yeah.
Okay, all right. So the traditional PSARP for treatment of rectovestibular fistula involves a midline incision from the coccyx extending anteriorly through the anal sphincter complex and the perineal body to the fistula tract itself, located within the vestibule. The advantages to this, it provides wide exposure and allowing for visualization of the muscles of the sphincter complex and the ability to properly locate the rectum within the sphincter complex. But the perineal body must be rebuilt. And so this technique compromises the integrity of this area, which inherently leaves a closure site that is vulnerable to dehiscence later. So in 2022, this is our first presentation of a modified technique with the goal to avoid this complication. And the idea is to preserve the goals and tenets of the traditional PSARP while keeping the perineal body intact. And so I'll show a series of video clips and note that the patient is in prone position. After the sphincters are identified, an incision is made only within the extent of the sphincter complex. And note how there's no posterior or anterior incision. Lone Star pins are placed to facilitate exposure. The dissection is carried down to identify the rectum, and the pins are advanced again, being careful not to tear the perineal body by adding excess tension. Let's see. And then here we're demonstrating the rectum. And then traction sutures are applied to the posterior rectal wall. Then the rectum is elevated and opened to allow for placing additional traction sutures. It's also important to dissect the posterior and lateral walls, because this will help identify the anterior plane of dissection. And so the anterior wall of the rectum is dissected and fully separated from the vagina, which is indicated by reaching this areolar tissue, confirming complete separation. So once the dissection is complete, the perineal body muscles, which have been splayed by the fistula, are sutured together to close that area where the fistula had been. And this will become the anterior limit of the sphincter. But note how the subcutaneous tissues and skin of the perineal body remain intact. After full mobilization, the anaplasty is then completed in the standard fashion, and the only incision is the anaplasty itself. Now, when we look at the spectrum of anomalies that we can see in the female, we see that starting with the normal position of the anus within the sphincter complex, that these malformations share an anterior position of the opening, just varying in its extent. And so we see here the fistula at the anterior limit of the sphincter, here within the perineal body itself, here the fourchette, and then here in the vestibule. And so when we're applying this technique, it is important to select for the appropriate patient. And it's really intended to be the rectovestibular fistula, because quite simply, there has to be enough perineal body to protect or preserve. And so more recently, we reported our early outcomes. And so looking at that patient population, we had a group of 15 patients. The median follow-up was 11 months with a range of 1 to 36 months. And we saw no perineal body dehiscence within that cohort, no rectal prolapse. We did have 2 cases of anal stricture compromising 13%. And then looking at secondary outcomes, 93% were resuming feeds on postoperative day 1, the majority discharged on postoperative day 1, all stooling spontaneously, and the majority of our population using laxatives. That is our standard protocol. So switching gears a little bit, looking at another complication. What is the complication that we see here? Is this a remnant of the original fistula? And we'll open up the poll, I think, again here.
Yeah, I'm going to start again. Yes, I've opened it up again, so it's about the second question now.
Yep, so going over the choices, remnant of the original fistula. Is this a urethral injury? Is it a normal urethrogram? And is this a product of a false passage from a traumatic catheter placement?
Yes, I'm going to wait a couple of more seconds. I can see that almost half of the attendees have voted. About 57% have voted, so I'm going to close the poll and share the results. I'm not sure if you can see the poll answers as well, Andrea.
Okay, no, I can see it. So 54% voted for roof, 29% urethral injury, 4% normal urethrogram, and 13% for a false passage. Now, this could be a roof. We're seeing contrast posterior to the urethra in this space. But what if I told you that this was from a perineal repair? I'm going to go and close this window. So how does a urethral injury occur in the setting of a perineal fistula? And so the urethra is quite close proximity to the fistula in this anterior area. And while this doesn't happen often to have injury to the urethra, it is has significant impact in terms of need for urethral intervention and repair, and can also impact fertility with injury to the vas deferens as it enters the urethra in this location. And so the morbidity from such a complication is quite high. So in 2022, the group at Nationwide described a modified cutback type procedure called the posterior rectal advancement anaplasty, particularly for rectoperineal fistulas. Again, going back to our spectrum of malformations, we're really looking for patients in which the fistula is at the anterior limit of the sphincter. And so the posterior rectal advancement anaplasty is really intended for cases in which the fistula is within the sphincter complex so that there's muscle surrounding the intended anaplasty. Luckily, this anatomic configuration is true for the majority of male perineal fistulas and many female perineal fistulas. And so looking at this example here, we have the fistula identified by the yellow circle, and you can see mucus just underneath this area. And then the sphincter complex is marked in blue, and so that the fistula is within the sphincter complex. When we look at some videos, again, the patient is in prone position. After marking the sphincters, an incision is made from the posterior aspect of the fistula to the posterior limit of the sphincter complex. The dissection is carried down to identify the rectum, and then laterally, ensuring to stay just on the rectal wall, focusing the dissection posteriorly. The rectum is opened, and traction sutures are used to assist in the dissection of the posterior wall. And it's important that this is mobilized. This is done without incising the posterior sphincter complex and without dissecting the anterior sphincter wall. And once the rectal wall mobilization is adequate and can be brought to the skin with an appropriate amount of tension, the anaplasty is completed. Again, the only incision left is the anaplasty itself. There's no sagittal incision component, and that has implications for postoperative care protocols. So what are the proposed benefits of the posterior rectal advancement anaplasty, or PRAA? Of course, without anterior dissection, this avoids the potential for urethral injury. With the incision limited to the anaplasty itself, patient can return to a regular diet immediately and be discharged the next day. And then potentially lower stricture rate because the anterior wall is left largely intact. And so again, our group recently reported some early outcomes with this technique. Just to tell you a little bit about our study population, as a referral center, we did have a percentage of patients who were referred with stoma, but who had the anatomic configuration that was amenable to this technique. The median age of repair is 162 days with a range of 1 to 242 days. But 44% of these patients were repaired quite young, before 1 month of age. And the median follow-up of 14 months of age with a range of 2 to 40 months. And here we see a postoperative picture showing that the only suture line is the anaplasty itself. In our group, we had no cases of urethral injury, prolapse, or wound dehiscence. and our stricture rate was 11%. Those two cases, they were both skin level, and so one was managed with a skin level anoplasty or HM anoplasty, and the other had dilations at home for a month, and then those were stopped. And this is an example picture of a patient who underwent a PRAA at 1 month post-op. And so looking at some secondary outcomes, all patients resumed feeds on postoperative day 1. The median discharge was postoperative day 1 with maybe an outlier, but a range of 1 to 6 days. And then all patients are stooling spontaneously with 80%, 83% taking laxatives. And so take-home messages. The modified PSARP techniques are really designed to avoid complications, in particular for rectovestibular fistula, the perineal body dehiscence. In the case of the rectoperineal fistula, urethral injuries. At least in early results, and we should be conservative, but there seem to be comparable or maybe even lower stricture rates compared to the traditional PSARP. I think the application of these techniques really requires appropriate patient selection. And then I do think that this is a reproducible set of techniques that can be taught to others, and happy to share anecdotes from our experience related to the learning curve and for the various techniques. And so thank you for your attention, the invitation, and more importantly, let's get to the chat.
Thank you very much, Andrea. It's beautiful videos and showing this technique very elegantly. And of course, people can also read the papers, I guess. I can't see the, Pamela, can you see the chat? Because I have some questions, but maybe the public have.
Yeah, so you can find the questions for Andrea. It's handy to stop sharing, I think, because then she is able to see the rest of the screen. But people can type in their questions in the Q&A section. So down below you have a Q&A with a question mark on it, and that is the place where you can type in your questions. Right now, I didn't see any questions come in yet, so we will give people some time to. I can see the first question has already been sent through.
And I can ask some start the discussion. The first question is, of course, tips and tricks. Are there more tips and tricks, Andrea? That's one of the questions. But
sure. Let me see if I can.
One of the problems may be when you show the triple P. Some people call it the triple P technique for the vestibular.
Yep.
If you put in the Lone Star pins, the wound sometimes start off with a very small incision on the muscle complex. But you put in the Lone Stars, then the wound becomes bigger. And it seems like you kind of disrupt the perineal body. Although we see, so could you elaborate a little bit on that?
Sure. I'm trying to get, let me go back. Let me go back to the queue up a representative image here. Okay. I'm going to go ahead and share again. And so I think when you get to this stage, it's very easy to start getting focused on what you can see in here.
Yeah.
And not what's happening here. You can see my pointer, correct?
Yes, we can see it.
And so one of the things that we started to do when we were noticing that is you can put a suture right here as a bolster to prevent that sort of inadvertent tearing. And then the other part is, of course, just kind of retraining yourself to be looking at this area because it is vulnerable to that tension. So you want enough to sort of obviously expose the area, and advancing the pins deeper also brings more light into field and brings the field closer. So it's not so much pulling outward, but also shortening the plane by advancing the pins deeper.
Yeah. It's a very, very nice technique. You said you could learn most people. One of the your
Yeah.
final slide, you said, do you think people should go somewhere where it's been done before, or could they start trying to do it? What would you be your
Sure. I mean, I think
Good-
there are a couple
good
ways
choice?
to answer that question. I think when it's available to you to see how somebody else does it, there are always those extra tips and tricks that we even forget to mention. So sort of starting with someone else can also be helpful. But one of the things that we have found that's helpful as we're learning, if you just can't get the exposure that you want, you can't see what you need to, if you feel like you need to extend the incision, extend posteriorly, extend this way as you're learning, preserve the perineal body, extend this way, and you will find that I think you develop that skill set in serial attempts, and that you'll get to the point where then you can keep it within the anaplasty. And there are always going to be those challenging outlier cases, even when you've been doing it for a while, where you're just not accomplishing the principles of the surgery. You don't want to sacrifice those to the bailout, or the helping hand is to extend posteriorly.
It does help when you've done enough PSARP procedures, because you can always convert to a PSARP if you don't have enough visibility or anything.
Correct.
So I agree. That's what we always discuss as well. Is one question from Catalina Diaz says, when do you repair an anterior anus? Well, that's a question.
That's a tricky question.
Yeah, tricky question. It depends on what you mean with anterior anus.
Yeah.
If it's in a normal, it's within the sphincter muscle, nobody really does anything. If you consider a perineal fistula and anterior anus, then it's like a perineal fistula. So, but I don't know what your
No,
thoughts
I was going to say the same. You know, the normal anus is defined by its position and location within the sphincter complex. So if it's got muscle all around it, that's where it needs to be.
A question on dilations. One from Daniel Aronson. Welcome, Daniel. Great presentation. How long do you have the parents to do dilations post-op? But I think you're not dilating the patients.
That's correct. So we do not do routine dilations. The dilations that I mentioned were in cases where there was a postoperative stricture. So in terms of routine dilations, we do not do them.
But you had there was 2 out of something, 13% stricture rate. So
13 and 11 for the 2 techniques.
Yeah, so it seems a little bit high. I'm not saying that it's high, but it seems a little bit high. Do you think dilations just as a standard care could prevent this, or do you think it's not, we shouldn't be doing it? Because this is a debate worldwide as well, whether we should do it or not.
You know, so from studies here, you know, 1 in 5 patients would get a stricture without dilations or not. And so if you look at that percentage, and of course it ranges from the series, I think that 11 to 13% for these 2 techniques is comparable, if not a little bit lower, but they're small series, right? So we would have to see more patients to know if that bore out. And certainly as more people are doing the technique, is it reproducible from that standpoint? But I think what we're seeing is comparable, if not lower.
And you think it's lower with this technique than in the PSARP, the stricture rate, or is it hard to tell? It seems a bit lower, but I'm not sure.
Yeah, so I would say maybe conceptually lower with the PRAA, because more commonly that anterior wall is left completely intact. So it's kind of akin to doing a prolapse repair and only doing half the circumference. You know, you're not fully dissecting it. So I think conceptually there's a potential for a lower rate. I think from the perineal body preserving, it's probably comparable, because you know you still are doing a circumferential dissection, but again the data needs to bear out with more examples.
And that's something, one of the question here, that's with Dalia from the patient and parent organization, also asked, do you get the same outcome as the PSARP in terms of continence? what you really want to look at when they're more or less
Yeah,
like
so
25 or something.
our patients are
But
too young to
can you say
answer.
anything about it?
So I think right now we know that they flow. These babies are still in diapers for the most part, and so we haven't gotten to the point where we can ask that question.
Yeah. But if they're within this muscle complex and they
Yeah,
have the same other structures, then it would at least be similar.
yeah,
And if
absolutely
you have,
correct.
yeah, and with less complications, you would think that you would get a better outcome. But
Yeah, I
it's
think,
these numbers.
conceptually, we're still trying to preserve those tenets and goals of the original traditional procedure. And so I would think conceptually that the potential is there for a similar, if not better outcomes from a continence perspective.
Okay, a question from Maruf Abdul Salam. And maybe I think you mentioned it, but maybe it's not clear. What happens to the fistula or the vestibular fistula in the PPP method?
Oh, no, you know what? I didn't
Maybe
show that in the video. So I would say there are two ways to deal with that. And some of it depends on whether the kids have been dilating before and how big that fistula is. What we do now is we put sutures on the distal fistula from the prone position and pass it through the vestibule, and then just put a couple stitches to close that mucosa just before we wake up the baby. We flip anterior and we just excise some extra tissue, and it's a very simple repair to close that mucosa. And the muscles are closed from behind already, which is the true strength of that tissue, that area of tissue.
Okay. And a question from Goncha Tekant. Thank you for the lovely presentation. Have you totally switched to all your patients with this technique? Did you change all
Yeah, so
more clinics, for example, your clinic, other clinics, or do you know how it works?
So again, you're asking if this is what we do exclusively for rectovestibular fistula. And so identifying that there's a rectovestibular fistula with an adequate perineal body to preserve, right? That's the case, then those patients are all getting this procedure.
Yeah.
And then similarly for the PRAA, or posterior rectal advancement anoplasty, if we have malformation where the fistula is at the anterior limit of the sphincter and there's sphincter anteriorly, then those patients are getting the PRAA.
Okay. And is it getting implemented in more clinics? Do you know anything about it, or?
In terms of sort of outside of our institution?
Yeah.
Yeah, so that's the antidote part. I think we get a lot of people who have reached out to share some of their success stories and their implementation in their local area, and some providers have done many patients like this. Of course, we hear of the success stories, but it seems to be catching on, and I think conceptually appeals to people, and it is something that's reproducible. And we're getting feedback in that regard.
Yeah, and with respect to that, we give a course at the EUPSA, but also in Stockholm this fall for residents, and we have a model where we practice the technique as well. It's not exactly similar, but we can show them the difference in technique and how to deal with it. So for the younger ones who want to train it a little bit by themselves, they can come to Stockholm as well.
That's a nice invite.
Yeah, just some public relations for this conference. Thank you for this, Roni Sweer. Thanks for the presentation. How do you explain stenosis, the strictures in both techniques? I think we just dealt with it. I'm not sure. Do you want to?
Yeah, I think particularly for the PPP, it's still a circumferential dissection. Anytime your suture line is a circle, when it heals, it wants to close down. So I think there's, an inherent principle there for stenosis. The PRAA, I think less so, but it depends how much of that dissection you're doing. And some kids do tend to fibrose and they have more of a fibrotic response in their healing. So I think those are the potential explanations.
Yeah, you probably can't prevent everything. Even wound dehiscence is not breaking off the perineal body, but a suture that gets loose from any technique can happen anytime with any patient. I mean, we don't control everything, I guess. Is there a link where we can rewatch the technique? Of course, you can watch it on this YouTube, but I think you have links as well on
Yeah, so it's
watching website or somewhere.
so the expertsinsurgery.com.
Yes.
And Dr. Levitt has a number of videos there that he's compiled, and we're looking to do some updated ones, and so that would be the place to get the full video. These are clips taken from there, but both of the master ones are on that site.
Okay. Then a question about age. What age do you perform the surgery? You had an average age, but do you have a preference? Would you like to do it as a neonate or
Well, so no, it's a good question. I think that it's applicable to a broad age range. I think when we're talking about very small infants, obviously there are some challenges with just size and the integrity of the tissue when you try to apply a Lone Star under tension, those sorts of things. We tend to have a referral population, so we are getting patients a little bit older sometimes, but still 44% of our initial population was 1 month or younger. And then we have heard from some of our partners around the world of applying this technique to older patients. And so we have done repairs in 12-plus-year-olds. I can't remember if maybe who the oldest patient is. And then there was a provider who did one in an adult patient, and it was not diagnosed.
Okay. So it could be any age, could be. But your preference for a male with a perineal fistula is as a neonate, or?
Yes, correct.
Yeah.
Correct.
Because we tend to dilate, to calibrate first, and then operate after 6 to 12 weeks. But I think it's still applicable then, as long as the stool comes out in the period. But some people prefer as a neonate.
Yeah, because even in our babies that have congenital cardiac disease, you do not need to be in prone position for the PRAA. And so it is applicable to even that population. But yes, sometimes there are medical reasons to wait as well.
Yeah, that's a question about from Mohammed El Ghaziri as well. Do you think supine position is applicable for vestibular fistula than prone?
So
now we're talking about the PPP.
Yeah, so our preference has been to dissect from prone. I think you can see better in terms of getting to that interface for complete separation between the vagina and the rectum, and really visualizing that areolar plane and knowing that you've completed the dissection, I think is best in prone.
Yeah. And then Ebert Schmideke, what happens to the fistula of the vestibular fistula in the PPP method? That's something we already discussed. Was not on the video, but in the other videos it is. But you just
no, that's why we were gonna do some updates to include that.
Yeah.
Sometimes the fistula is very minute, minuscule, and there's not much tissue. You can actually close it from the prone position. But for the larger ones, it's easier to pass the tissue through, trim some of that, and do a primary repair with just 1 or 2 stitches.
Okay. Well, I think everybody's enthusiastic about it, so I'm not sure what will happen. You said it's a modification of the PSARP. In a way it is, but it is also kind of different than the PSARP. I mean, you do cut the muscle complex, but you try to spare as much as possible.
Yeah, I guess the things that I think about are, really designing the surgery around the sphincter complex, right? It's identification of the sphincter complex, staying within those muscle boundaries. And you're still trying to get the full dissection, staying on the rectal wall, full separation from the vagina. And those ways, those are the kind of things that I was thinking about in terms of preserving the goals and tenets.
Yeah. Okay.
I can
Thank
see.
you very much. It was, I think a lot of people liked it very much. I liked it very much, particularly with the videos.
Thank you.
Famida, are there any other questions or items we need to discuss?
I think we went through all the questions except for one maybe. Paul Stevens asked, Thank you for the presentation. You mentioned all patients are discharged with laxatives. What is your laxative protocol?
Yeah, so usually we'll start the kids on either like a low dose of Senna, 2.5 milliliters, and a half cap of Miralax, depending on if they're formula fed or breast milk fed. If they're breast milk fed, then that's the laxative and we don't add anything. But the idea is to keep the stools loose, at least for the first month. And then we can peel back and just go with Senna, aiming for a good bowel movement pattern and consistency.
Great, thank you. And then another question came in just at the end.
2 more questions, I see. Yeah.
Yeah, somebody asked, how do you manage the wound from fecal contamination?
So we don't, in that there's going to be poop there, but I think it's about managing the consistency of it. You really don't want a very hard formed stool in that early healing phase. We use that day or overnight in the hospital to teach kind of basic wound care, or taking care of the sutures, rinsing the area, patting it dry, those kind of things, to try and reduce the fecal debris burden. But it's more about the consistency and the pressure, I think, more than the stool itself.
Okay. Oh, there's new questions coming up, Amalia. One of Luc Matthijssen. When do you expect to have the continence data for both legs? That's probably a couple of years, I guess.
Yeah, they need to grow up, right? So usually we think about potty training age. And so, typically around 4 or 5 years of age. And so, we'll let you know. We'll announce it when it's out.
Yeah. And then an interesting question of Eva Amerstorfer. Thank you very much for sharing your experience. What do you think about the sensitivity of the fistula part when you see anal crypts in vestibular fistulas? Would you also preserve that part? Is there a way? But it's going to be, I think it's going to be very difficult in the PPP technique.
Yeah.
So if you have a larger fistula, sometimes you can see crypt-like structures.
Yeah,
Is there a possibility to preserve it?
So I think when we see it and you see it looking like normal anatomy, you don't want to sacrifice it. But I think it's most amenable in the PRAA because that anterior rectal wall is intact, and so it's there. Less ability to really do that in the PPP.
Yeah. Then you have to make a choice either to leave it there or you have to replace it or remove it or replace it in the muscle complex. Okay.
Great. I think that was actually it now.
Yes.
Thank you so much. There were a lot of questions, and it's a very interesting topic. So thank you again, Andrea and Ivo, both of you, for being here, for doing the presentation and the discussion. Thank you for the attendees who have joined. I would like to mention that the webinar has been recorded. So I will be sending the link for the YouTube channel tomorrow. You can find all of our webinars there. You can find a playlist for all the colorectal webinar series. So keep that in mind. And for the attendees who have watched live, you will receive a survey after the session has finished. If you fill that in, you will improve, you will continuously improve our sessions, but you will also get a EACME certificate after 2 weeks. So make sure you fill that in. Again, thank you all very much, and I wish you have a nice evening and day for you, Andrea.
Thank you. Thank you.
Thank you very much, Andrea. Thank everybody for listening, and thank you, Pamela, for organizing the webinar. Bye.
Bye-bye.